and in today's session I'm going to discuss about fractures of the midface of the facial skeleton. We are all aware that fractures along with the mandible midfacial skeleton is also very much prone to fracture. Now, how will you demarcate the midfacial skeleton from the facial skeleton? Okay, you will make a line starting from the frontozygomatic suture on one side, crosses horizontally the nasal bone and the lacrimal bone, fracturing the nasofrontal, the nasomaxillary and the frontomaxillary suture, and fracturing the zygomaticofrontal suture superiorly. And inferiorly it is bounded by the occlusal of the maxillary plane, or in case of an edentulous maxilla, it could be the edentulous ridge. The posterior limit is the junction between the sphenoethmoidal bone, including as you move posteriorly and inferiorly, it separates the pterosphenopalatine plate from it. So basically, there are 8 paired bone and 2 unpaired bone in the midfacial skeleton. So what are these 8 paired bone? The 8 paired bone are the maxillary bone, the 2 palatine bone, the 2 zygomatic bone, the 2 zygomatic process of the temporal bone, lacrimal bone, the 2 nasal bone, and the inferior concave. Unpaired bone is the ethmoidal bone along with its concave and the vomer. Now, before we go on to the clinical characteristics of midfacial fracture, there are few physical characteristics that we need to know regarding the midfacial skeleton. As I mentioned earlier, midfacial skeleton is made up of a number of bones. Now, these number of bones articulate in a complex fashion. Okay? But these bones are very fragile, and these fragile bones are supported by strong buttresses. Now, why do we need to have these kind of bone? Because as we see, the greater portion of the midfacial skeleton is made from the maxilla, which articulate with these very fragile bone. So what happened? It acts as a shock absorber and has a cushioning effect. When any kind of trauma is occur on the face, so these bone try to fracture and protect the anterior cranial fossa or the orbital content from getting damaged. That is, they protect the vital structures like the orbit and the brain from getting damaged by fracturing itself. Now they are very sensitive to force that are applied in the anterior and lateral direction. But because of these strong vertical buttresses, they are able to withstand force of mastication. Does any other force that is applied in the sideways, that is the lateral and frontal direction, they are very fragile to it. But masticatory force, they can tolerate very well. Now, the frontal bone and the body of sphenoid, they form an inclined plane that slope downward and backward, and it is at a degree of 45 angle. So whenever fracture of the midfacial skeleton occur, there is movement of the fractured segment slightly backward and marked movement in the downward direction. Now this results in elongation of force, and since the fractured segment is moved downward in the inferior direction, the posterior teeth come in contact with the posterior mandibular teeth, resulting in posterior gagging and cause a classical anterior open bite. Now, because of these fragile bone, that is the nasal, the ethmoidal bone, they get fractured when force is applied in the anterior direction. When they get fractured, the paranasal sinuses get exposed. Thus, chances of infection increases in the maxillary fracture compared to the mandibular fracture. At the same time, these fragile bones, that is the floor of the orbit, also tend to get fractured. So there are tendency of orbital injury when there is maxillofacial, midfacial skeleton fracture. Now, in case of a high level of fracture, the cribriform plate of the ethmoidal bone get fractured. This causes a direct communication of the fracture site to the anterior cranial fossa and also causes CSF leak. Now, you might be wondering, a comminuted type of fracture takes place in the maxilla because of the multiple fragmentation, but the healing is not affected. Yes. Now, this healing is not affected because of the main reason that all of these bone is surrounded by a large layer of the mucosa, which is highly vascularized. That's the reason why any kind of fracture in the maxilla heals faster compared to the mandible, because of its more rich vascular supply. Let's move on to the buttresses. You might be wondering, I'm continuously talking about fragile bone and buttresses. Yes, in midfacial skeleton, there are 3 vertical buttresses and 3 horizontal buttresses. Now these three vertical buttresses is from the pyriform area is one buttresses. It starts from the canine region to the pyriform area to the max frontomaxillary suture or frontomaxillary junction. Then the second buttress starts from the first molar to the zygomatic buttress and the zygomaticofrontal bone. The third buttress is in the pterygoid area. Now then you have the horizontal buttresses. Now these are the supraorbital rim, the intraorbital rim and the occlusal surfaces. Now what are the importance of these buttresses? These buttresses have dense bone, now which can be used during plating or fixation when you are trying to reduce and fix the fractures. Since there are very fragile bones, these fragile bones you cannot plate and screw them. So you need some hard dense bone where you can put your hardware and fix the fractures. So these buttresses provide you a place to stabilize the midfacial skeleton. As you're all aware, when you construct a house, you build it on pillars. So these buttresses are actually pillars that hold your midfacial skeleton in position. Let's move on to the nerve supply of midfacial skeleton. It is mainly supplied by the second division of the trigeminal nerve, that is the maxillary nerve. And the blood supply is from the third part of the maxillary artery. Now let's move on to the classification of midfacial skeleton. An experiment was conducted by René Lefort on cadaver's skull, and he found that when force was applied on the skull in different direction, they have a specific type of fracture line. He removed the soft tissue and tried to examine the fracture line and came to a conclusion that there are three specific type of fractures that occur in midfacial skeleton, and he divided them into Lefort 1, Lefort 2 and Lefort 3 fractures. Erickson in 1942 divided midfacial skeletal fractures into horizontal fracture, pyramidal fracture and transverse fracture depending upon the design of the fracture line. Depending upon the relationship of the fracture line to the zygomatic bone, we can also classify them below the zygomatic bone fracture, that is subzygomatic fracture, above the zygomatic bone fracture, that is suprazygomatic fractures. Depending upon the level of fracture, it could be low level fracture, high level fracture or a mid level fracture. Let's move on to the clinical features of each of these fractures. We begin with Lefort 1 fracture. Now the thing that you need to keep in mind is the fracture line. In case of Lefort 1 fracture, the fracture line passes from the lateral part of the anterior nasal spine above the root apices of the tooth and move to the anterior wall of the maxilla below the zygomatic arch and moves posteriorly and fracture the pterygoid plate between the upper 2/3 and the lower 1/3 region. It occurs bilaterally. Hence, it is also called as low level fracture or subzygomatic fracture. In this type of fracture, the antedentoalveolar segment is completely mobile. So if you see its clinical feature, there will be slight swelling, mild edema, more commonly concentrated over the lower lip. There will be ecchymosis bilaterally, in the buccal vestibule or labial vestibule. Bilateral epistaxis will be there. You could easily mobilize the dentoalveolar segment with your hand. It is also called as floating fracture or Guerin fractures. Occasionally, the posterior tooth might fall down, which will hit onto the posterior mandibular tooth, resulting in posterior gagging. Sometimes impaction can also take place of this fracture segment superiorly. When you percuss on the maxillary teeth, a crack cup sound is heard. This slide show a 3D CT scan where you could appreciate the fracture line passing from the lateral part of the anterior nasal spine below the intraorbital foramen on the anterior wall of the maxilla. It dips down below the zygomatic bone and then fracture the pterygoid plate at the junction of above 2/3 and lower 1/3. Let's move on to the clinical features of Lefort 2 fractures. These are also called as pyramidal fracture and they are also subzygomatic fracture. Now why pyramidal fracture is because of their shape. Here the fracture starts below the frontonasal suture. It fractures across the nasal bone, the lacrimal bone and the zygomaticofrontal bone. It moves anterior to the lacrimal duct, crosses the infraorbital rim. It may fracture the intraorbital foramen either above or below it, but most of the time it is below it. Move along the anterior wall of the maxilla, go below the zygomatic arch and fracture the pterygoid plate in midway between the upper and the lower third. Alright, this takes place on both the side, hence it is also called as pyramidal fractures. Now here there is gross edema of the middle third, comparatively more than the Lifford one type of fracture. Now this is classically called as ballooning or moon face. There is bilateral circumorbital edema and ecchymosis resulting in black eye. There is bilateral subconjunctival hemorrhage wherein the medial limit of the hemorrhage is not defined. There is nasal disfigurement. The nasal bridge is depressed because of the fracture of the nasal bone. There is flattening of the face with the anterior open bite. Okay, the face will become short with anterior open bite in case of impaction. If the fractured segment moves down, then there is posterior gagging and elongation of the face. There is a typical dish face deformity. Why I am stressing on this is because the fragile bone, that is the ethmoidal bone, the vomer bone, they fracture. When they fracture, the entire segment will slope posteriorly. As I mentioned earlier, it will move posteriorly, resulting in a dish face deformity. There is bilateral epistaxis. There is difficulty in mastication and speech. Because of the paranasal sinuses getting exposed, there is surgical emphysema. In case when the cribriform plate is ruptured, there is CSF leak. Or a step deformity can be seen in the buttress region and anesthesia over the cheek. This slide shows a clinical feature of a patient with a road traffic accident. You could appreciate the amount of edema that is present. There is periorbital ecchymosis and hemorrhage on the right eye. You can see the laceration, bruising that are present, facial asymmetry. This is the post-operative image of the patient wherein you could see an antimongoloid slant. I'll discuss about this antimongoloid slant later. Let's move on to the clinical features of Lifford 3 fractures. Okay, in case of Lifford 3 fracture, your fracture line will start from the frontozygomatic suture. It breaks the frontozygomatic suture on one side. Okay, move along the lateral wall of the orbit, just below the posterior part of the inferior orbital fissure, move to the middle wall of the orbit, fracture the lacrimal bone, okay, fracture the frontonasal suture, then move to the other side, similarly to the frontozygomatic suture on the other side. There is a transverse fracture, okay, and posteriorly it fractured the pterygoid plate from the above. There is complete pterygomaxillary disjunction that has taken place. The entire segment is mobilized. It could also be accompanied with fracture of the zygomatic arch or the zygomatic bone. Now here there is severe edema which is more than that of Lifford 2. So hence it is also termed as panda face deformity. There is bilateral ecchymosis, periorbital ecchymosis and hemorrhage resulting in raccoon eye. Bilateral subconjunctival hemorrhage wherein the posterior limit is not seen. Now in this case, posterior limit is not visible because there is fracture of the lateral wall of the orbit. That's the reason why there is a lot of bleeding and you cannot see the posterior limit of the hemorrhage. There will be enophthalmos. There will be diplopia. Now blurred vision. Now all these kinds of optic deformity is there because the orbital wall is fractured. The content of the orbit is changed. The content is either increased or decreased and the framework is disrupted, resulting in enophthalmos diplopia. There is nasal deformity, epistaxis, CSF rhinorrhea. This slide shows clinical feature of the patient with road traffic accident with a classical panda face. You can see bilateral periorbital ecchymosis and the edema. The patient is, because of the severity of the edema, the patient is not able to open the eye. You can see the nasal deformity, a Ryle's tube is placed. The patient, it's very difficult to do mastication and speech. Patient is not able to eat, so you put a Ryle's tube so that you can start with the feeding. Now, let's move on to the fracture of the zygomatic complex. Now, after the chin, the cheek is the most prominent part of the face. Now, when any kind of trauma or any kind of injury or assault is done on the face, the cheek is the most prominent part that get hit. Okay, so maxilla fracture, zygomatic fracture does not take place alone. Now, because zygoma is attached to maxilla, frontal and temporal bone, thus there will be a complex that is fractured, that is zygomatico-complex fracture, or zygomatico-maxillary complex fracture, or a tripod fractures. Okay, now let's move on to its classification. Rowe and Kennedy has divided into 8 types. Type 1 is non-significantly displaced fracture. Type 2 is fracture of the zygomatic arch. Type 3 is rotation of the arch along the vertical axis. That is, there is inward displacement of the orbit, outward displacement of the orbit. Type 4 is rotation that occur at the longitudinal axis. That is, the frontal process is either displaced medially or laterally. Type 5 is displacement of the entire complex. The entire zygomatic complex move medially, laterally or inferiorly. Type 6 is displacement of the orbitoantral portion either inferiorly or superiorly. 7 is displacement of the orbital rim segment, and 8 is complex comminuted fracture of the zygomatic bone. Now Rowe has modified this classification and grouped them into Group A, Group B and Group C. Group A is stable fracture that show minimal or no displacement and does not require any intervention. Whereas Group B is unstable fracture. There is greater amount of displacement where you need to reduce open reduction, do an open reduction and internal fixation. Type C is a stable fracture with other type of fractures like zygomatic arch will also be fractured along with the complex. Now fractures of the zygomatic arch can also occur as a separate entity. Now this can be classified as minimally or non-displaced fracture, V-type fracture of the zygomatic arch and comminuted fracture of the zygomatic arch. Now what are the signs and symptoms of zygomatic complex fracture? There will be flattening of the cheek. There will be unilateral epistaxis, circumorbital edema and ecchymosis, subconjunctival hemorrhage. There is depression of the ocular level, limitation of ocular movement. There could be proptosis of the eye. Blurred vision can occur, blurring of vision can occur, diplopia can occur. Anesthesia of the cheek, traumatic emphysema, Steph deformity can be palpated in the intraorbital region and the buttress region. Ecchymosis and tenderness can be seen in the upper buccal vestibule and ophthalmos can occur. Now this slide show a picture of a patient with a road traffic accident wherein you could see there is unilateral periorbital edema and ecchymosis. Okay, there is an anti-mongoloid slant. The orbital level is not the same. On the profile view, the mouth opening is normal. In cases where the zygomatic complex is depressed inferiorly, the mouth opening is restricted because it will hit on to the coronoid process. At that time, the mouth opening is restricted, but in this case, it is not that much displaced, thus the mouth opening looks normal. On the lateral view, you could see the flattening of the cheek. This is best appreciated in the bird's eye view or worm's view, wherein you could appreciate the cheek on the injured side is depressed, whereas the other side is with the normal contour. Here the anti-mongoloid slant is present. Now what I mean by the anti-mongoloid slant? Our globe is supported by suspensory ligament of Lockwood. Now this ligament is attached to the Whitnall's tubercle. Now Whitnall's tubercle is present just below the frontozygomatic suture. When the fracture occurs below the frontozygomatic suture, the ligament is attached to the Whitnall's tubercle and the globe level is not affected. But if the fracture occurs above the frontozygomatic suture, this causes depression of the ligament down because and eventually the level of the globe is disrupted, resulting in an anti-mongoloid slant. On occlusion, the occlusion looks stable. Wherein there is marked depression, there will be posterior gagging. So you will have one cross bite and the other open bite. But here in this case, the occlusion is normal. Now what are the radiograph that you need to do? We start with a conventional radiograph, like you could do a PA Waters view, Cardwell's view, submental vortex view, and the most advanced technique, that is CT scan or 3D CT scan. Now what exactly is PA Waters view? In PA Waters view, you put the cassette, that is the X-ray film, in front of the patient and ask the patient to tilt the head at an angle of 45 degrees in such a way that the chin rests on the cassette and the X-ray beam is projected from behind the patient in the occipital region. Now, this technique is best to evaluate zygomatic fracture, especially that is useful in case it will help you to identify fracture of the infraorbital rim, fracture of the lateral orbital rim. It will help you to see whether the fracture is from the zygomatico, frontozygomatic suture is fractured or not. You can see fractures in the maxillary sinus. You could see the orbital content that is herniating into the maxillary sinus in this type of radiograph. Then the next is submento vortex view. Now in this view, you put the cassette film, that is X-ray film, behind the patient's, that is head, that is skull. Ask the patient to tilt the head markedly and you direct the beam, okay, from here in this direction. You make a line from the angle of the mandible. In the midline, you direct your X-ray beam. Now this technique is best to visualize fractures of zygomatic arch, and it also helps us to assess the symmetry of the malar projection. Now the best thing is the CT scan, which is the need of the hour nowadays. Now in this CT scan, you could see an axial section which shows fracture of the zygomatic arch and the anterior wall of the maxilla. This CT scan will show the fracture of the lateral wall of the orbit. Along with that, you could appreciate the fracture of the frontozygomatic suture and herniation of some amount of orbital content, because in the coronal section you could see the fracture of the floor of the orbit. This is 3D reconstruction, which will give you a three-dimensional view of the fracture. Then diplopia is one of the complications that arise in Lefort 2, Lefort 3 and zygomatic complex fracture. Okay, now diplopia is nothing but blurring of vision or double vision. But we need to identify the two types of diplopia, whether it is monocular diplopia or binocular diplopia. Monocular diplopia is when you have a blurred vision when one eye is closed through one eye by keeping the other eye closed. Now it is an emergency condition. It requires an immediate ophthalmic consideration, because here there is injury to the globe itself. So you need to treat it promptly to preserve the vision. Whereas binocular diplopia is when the patient sees double vision or blurred vision from both the eye. Now binocular, that is diplopia, can be because of physical interference, functional interference or neurological causes. Now physical interference is there is presence of edema in the extraocular muscles, or the extraocular muscles, they get entrapped into the fracture, they get entrapped into the floor of the orbit, or there is herniation of the periorbital content into the sinus wall. Now all of this are physical interference that could alter the globe position and result in diplopia. Functional interferences wherein there is interference in the muscle. Okay, inferior rectus muscle and inferior oblique muscles get trapped. So this is functional interference where the muscle is not able to move. Neurological causes, because there is superior orbital fissure syndrome. There is a specific nerve injury or cranial injury wherein the specific nucleus is affected. That could be neurological cause. Now diplopia could be temporary or permanent. Now most of the time what happened, temporary diplopia is seen early and it is of shorter duration. Once you reconstruct the orbit, remove the orbital herniation, put the muscle in normal position, it will subside. Okay, permanent diplopia is most commonly occur post-surgically. This is because of scarring that take place and fibrosis, wherein some amount of fatty tissue or muscle gets still entrapped after the reduction. Some amount of muscles and fat tissue that are still entrapped and you have not released it. They undergo scarring and fibrosis and they result in permanent diplopia. Now how do you test the diplopia? Okay, you check the movement of the patient in all possible directions. You keep an object at an arm distance from the patient. Ask the patient to close one eye and move the object in all directions, and ask the patient to inform you when he sees double vision. This is the way how you check diplopia. Then you could also do a force duction test. Force duction test is wherein you anesthetize the area. You take a forceps and hold the inferior rectus muscle and ask the patient to move the orbit upwards. If the patient is not able to do this, this is because the muscle is getting entrapped into the fracture. Okay, this is how you come to identify that there is diplopia because of muscle entrapment. Then let's move on to enophthalmos. Enophthalmos is nothing but inward shrinking or sinking of an eye. Now there is accentuation of the upper eyelid hooding, anterior projection of the globe while viewed from above is reduced. Now basically the eye goes inside the socket, that is enophthalmos. Now why does the eye goes inside the socket? Now this can be because the volume is decreased because of herniation of the orbital content into the sinus, or because the volume is increased because of the displacement of fracture of the lateral wall or the medial wall or the inferior wall of the orbit, the volume is increased. So the globe shifts inside, resulting in enophthalmos. It is an emergency condition. It needs to be treated surgically. We need to construct the orbit, restore the form so that the volume is normal and enophthalmos is decreased. Let's move on to the treatment of midfacial fracture. Now, the treatment can be divided into emergency or initial care, early care, definitive care, and secondary care or revision. In emergency and initial care, you evaluate the airway first. See the existing airway of the patient, identify if there is any kind of airway obstruction. Then you manipulate the airway. If there is anything in the mouth like an fractured tooth, blood clot, or a denture, try to remove it. Once you have done this, increase the airway by doing head tilt and chin lift technique. Or you could do a jaw thrust technique wherein you put both your fingers on the inferior border of the mandible, thumb on the anterior part of the mandible, and you try to open it. Okay? This is done to increase the airway. If you are not able to maintain the airway in this position, then you might opt to do an intubation. In case where intubation is also not possible, then you also have to offer surgical airway like tracheostomy or cricothyrotomy. Now, once your airway is secure, you check the spinal injury, cervical spine injury. Whenever a patient comes with a trauma, always consider that the patient is having cervical spine injury unless you have ruled it out. Otherwise, always treat the patient like they have a cervical injury. Put a cervical collar, stabilize unless you surely know, there is no cervical injury. Then after that, check the other system, like check for head injury, chest injury, abdominal injury, and if there is any kind of limb fractures. Now, once you have checked that, you treat the bleeding, because hemorrhage is the most common cause of shock that occur after injury. Now, multiple injury, that is patient undergo hypovolemia. So the goal is to restore the organ perfusion. So if there is any kind of external bleeding, put pressure pack and start with an IV access. Start with ringalactate, normal saline, or if required, do a blood transfusion. Now, facial laceration, if they are small, you could do it in an emergency or in a casualty. If there are extensive laceration on the face and scalp, then take it inside an OT and do it in an aseptic condition. So soft tissue injury, you control the hemorrhage, do thorough debridement, suture, put a dressing and start an antibiotic along with a tetanus prophylaxis. Let's move on to the definitive management of midfacial skeletal fracture. Now, as you treat the fracture in any other part of the body, fracture of the maxilla is also treated similarly. That is reduction and fixation. Now, reduction you could do by manual reduction, either by simple digital manipulation, like in case of Lefort 1 fracture, wherein the dentoalveolar segment is mobile, you could do finger manipulation. Or you could use instruments for manipulation. You have Rose maxillary disimpaction forceps and Huyton-Williams forceps. Now, these are used in case of Lefort 2 and Lefort 3 fractures. Now, Rose maxillary disimpaction forceps, they are paired forceps. They have two beaks. One beak goes inside the oral cavity and the other beak goes inside the nasal cavity, and you mobilize and reduce the fracture. Huyton-Williams forceps is a single forceps which actually hold the maxilla circumferentially. It is used in case where there is mid-palatal split to reduce it. Now, reduction can also be done with the help of traction. Now, these are done in delayed cases wherein the patient had come to you after 10 to 14 days. So there is some amount of fibrosis wherein you cannot do reduction. You have to do reduction by retraction, by putting elastics. Now, elastics will get the occlusion into a normal position. Once the occlusion come to normal position, you will do intermaxillary fixation. Now, in case of maxilla, the minimum time that is required for intermaxillary fixation is 3 to 4 weeks. You could also support this intermaxillary fixation with the internal skeletal wire suspension. Now, wires are passed subcutaneously from stable skeletal point into the intraoral and are fixed on both the sides by the arch bar under traction. Now, in case of Le Fort 1 fracture, you will do intermaxillary fixation and do a suspension wiring along the zygomatic arch. If there is Le Fort 2 fracture, you will do suspension wiring along the zygomatic arch. After intermaxillary fixation, you could also aid by doing internal skeletal wire suspension. Now, this internal skeletal wire suspension, a wire is passed subcutaneously from a stable skeletal point in the oral cavity and are fixed on both the sides with arch bars. Now, in case of Le Fort 1 fracture, you will do intermaxillary fixation and zygomatic arch suspension wiring. In case of Le Fort 2, you will do zygomatic arch suspension wiring or frontonasal bone suspension. In case of Le Fort 3, you can do zygomatico-maxillo-frontal suturing or bilateral frontomalar suspension. Let's move on to open reduction and internal fixation. In case of Le Fort 1 fracture, you will give an intraoral incision, expose the fracture side, and you will do plating. Here our buttresses come into play. Okay, that is the two buttresses, vertical buttresses. You will put L-shaped plate in the piriform aperture and in the buttress region, that is in the molar region, as you can see in the photograph. Now, when you're using an L-shaped plate, you see that you put two screws above the suture line, fracture line, and two screws below the fracture line. In case of Le Fort 2 fracture, you will put a Y-shaped, inverted Y-shaped plate in the frontonasal area. You will put a 4-hole transverse plate in the intraorbital area and an L-shaped plate in the buttress area. Now, in case of Le Fort 3 fracture, you could put an inverted Y-shaped plate in the frontonasal area and longitudinal plate, that is a 4-hole transverse plate in the lateral orbital rim. You could also put an L-shaped plate in the buttress area if required, or you could directly put a transverse 4-hole plate in the zygomatic arch, depending upon the type of fractures. Now, let's move on to the treatment of zygomatic complex fracture. There is always a debate whether we need to treat these fractures or not. Now, when do you not touch these fractures? Like, when do you not do an open reduction for these fractures? When they are minimally displaced, or when there is less cosmetic deformity, the disturbance of vision is not there, there is no paresthesia, there is no impaired in the mandibular movement. In that case, you don't have to touch the fracture. It is not displaced, it will automatically heal. Okay, now when do you have to treat the fracture? Now that also, when you're treating, it could be just close reduction or open reduction internal fixation. Now, close reduction are done in those cases where there is minimal displacement. So you just do a close reduction and keep it. Open reduction is done in those cases where the displacement is marked. When you need to restore the internal orbital reconstruction, at that time we do open reduction internal fixation. Now, the advantage of open reduction is that anatomic and functional restoration is done. You are able to visualize the area anatomically, so you are able to restore it properly. The orbital anatomy and volume is restored. Now, disadvantage of close reduction is the treatment is limited to using bone hooks or Carroll-Gerhardt screw. There is lack of visualization of fracture segment. There is no fixation. You're just moving it and keeping it like that. What if a trauma occurs? It will again displace. Okay. Now, similarly, the disadvantage of open technique is that you might have to give an extra incision to expose the area. But most of the time, there are skin laceration. You can go through these skin laceration. Now, injury, it might happen that you're trying to fix it. You might cause injury to the global periorbital content or injury to the intraorbital nerve, which will result in paresthesia. So these are the drawbacks of open reduction. Now, indication for surgery. Okay, when do you actually have to do the surgery? When there is alteration in facial contour, where there is globe displacement, that is there is enophthalmos, diplopia. Okay, where there is muscle, fat or nerve entrapment in the fracture line. I mean, there is mechanical restriction of mandibular movement. In that case, you have to open up a fracture, reduce it openly and then fix it. Now, factors affecting the optimum time of operation. Now, these are the presence of ophthalmic injury, progressive proptosis, deterioration of visual activity, the visual integrity of the unaffected side. The necessity of immediate operation is related to the facial or general condition of the patient and medical condition of the patient. Now, what is the actual optimal time for surgery? Now, During 5th to 10th post-operative day is very critical, wherein the edema will subside. Okay, once the edema subsides, you could do a detailed examination of the eye and also assess the post-traumatic diplopia. The hematoma will start to is not organized into fibrous tissue, and in this time the dissection is comparatively easier. But as time passes, after 2 weeks, fibrosis start to develop, and after 3 to week, final union take place. So the ideal time when you have to touch a zygomatic complex fracture is 5 to 10 days post trauma. Now, for plating it, you need to expose it. To exposing it, you need to know the different type of approach that are available. Okay, you could treat a zygomatic complex fracture by intraoral approach, that is maxillary vestibular incision. You could give a supraorbital eyebrow approach or upper eyelid approach. You could also do a lower eyelid approach. Lower eyelid approach is further divided into three: subciliary approach, lower eyelid approach, and intraorbital approach. Now these also depend upon if there is any pre-existing scar. The surgeon will always prefer a pre-existing scar rather than putting a new scar, because it's face, it will scar, it will look uglier. So if there is a present scar, you expose it from that area only. Now once you've exposed it, you will reduce it. Now reduction can be done from the temporal fossa approach. In this case, you ask the patient to shave the area in the temporal region. You'll make a 2 to 2.5 centimeter incision at 45-degree angulation from the zygomatic arch. Once you have done the skin incision, you will expose the fascia, the temporalis fascia, glistening fascia you could see. You cut through the fascia, expose the muscle, put your Bristow elevator between the fascia and the muscle and try to palpate the arch from extraorally and from inside. You will go below the arch and try to apply the pressure upwards so that you lift the arch and move it outside. You could also offer an intraoral buccal vestibular approach to reduce the zygomatic complex, or a lateral coronoid approach, or a percutaneous approach. In case of percutaneous approach, you could move the zygomatic complex bodily outward. In this case, Carroll-Girard screw is used. Now once you have done the reduction, you have to do fixation. Now when to do fixation and when not to do fixation, okay? Non-displaced fracture, you need not have to do any surgical intervention. And if it is displaced fracture, you could do either 1 point or 2 point fixation is sufficient. Okay. Now when to do what type of fixation? Okay. If there is fracture of the buttress, then you have to do 1 point fixation from the intraoral approach. If there is fracture of the frontozygomatic suture, then you have to do 2 point fixation, wherein you will expose the frontozygomatic area from the supraorbital incision. Okay, you plate the frontozygomatic area, then the buttress area. When there is fracture of the intraorbital rim also, you will do 3 point fixation. The order is frontozygomatic area, intraorbital rim, and the buttress. 4 point fixation is done in case where the zygomatic arch is also fractured. Now, once you have done the fixation, what are the post-operative care that you have to take? Patient vision should be evaluated post-operatively, regularly. Okay, head is kept in an upright position to improve the periorbital edema and pain. Prevent any kind of orbital emphysema by telling the patient not to blow the nose at least for 10 days following the orbital surgery. If the patient feels like sneezing, patient can hold the nose at the time of sneezing. It will automatically stop. Then, ophthalmic evaluation is must. When you're doing that, you should check the vision, extraocular movement, diplopia, globe position, lid position. If the patient complain of tear flow, then you have to check for the lacrimal duct. Then start with medication. Give a proper coverage of antibiotic. Since in high Lefort fracture or zygomatic fracture, paranasal sinuses are exposed, the chances of infection is more. So start an antibiotic, nasal decongestion, steroid to decrease the inflammation, and ophthalmic ointment. Now post-operating imaging is a must. This will help you to identify that what you have done, the reconstruction is proper or not. And this will help you to document the case, see the pre-treatment and the post-treatment radiograph. Then wound care, apply lot of ice pack for the starting 24 to 48 hours. Suture the area, keep the suture for at least 7 days, do suture removal after 7 days. Avoid any kind of sun exposure and tanning on the skin incision for several months. Then diet. Soft diet is taken, okay, till the intraoral wound is healed completely. But if there is intraoral wound dehiscence or bone exposure, in that case, you will put a Ryle's tube and do an intranasal feeding. In case you have put the patient of intermaxillary fixation, you will ask the patient to have liquid diet until the IMF is removed. And more commonly in the maxillary fracture, intermaxillary fixation is removed after 3 to 4 weeks. Now, complication that can arise in case of treating zygomaticomaxillary complex fracture or midfacial skeleton fracture. Failure to restore the anatomical contour can take place, resulting in malocclusion. There is infraorbital nerve injury resulting in paresthesia. There could be anophthalmos. You're trying to reconstruct the orbit, but there are no sufficient bone or you're not able to reconstruct it properly. Can result in anophthalmos or post-operative diplopia. There could be infected hardware, there could be altered vision, anosmia, sinusitis, non-union and CSF leak can also take place. Now with this I would like to conclude by saying that midfacial fracture occur in a wide variety of patterns and the various extended access approaches can be used to treat these kind of fracture. But restoration of facial buttresses is crucial to re-establish the pre-traumatic aesthetic and function of the facial skeleton.